Hello, this module will cover the definition, classification, pathophysiology, and treatment of pneumothorax. Pneumothorax is a collection of air outside the lung but within the pleural cavity. This abnormal air accumulation disrupts lung function and often leads to partial or complete lung collapse. The following section will be the anatomical structure of the human lung. The lung's anatomy begins with the trachea branching into the right and left main bronchi, which supply air to their respective lung lobes. At the microscopic level, alveoli facilitate gas exchange, while the diaphragm serves as the primary muscle of respiration. Pleural cavity is bounded by two serous membranes, the visceral pleura covering the lungs and the parietal pleura lining the thoracic cavity. Between these layers lies a potential space containing lubricating pleural fluid, maintaining negative pressure for lung expansion. Pneumothorax incidence varies significantly by type. Primary spontaneous pneumothorax occurs in approximately 7 per 100,000 in the male population annually and 1/100,000 in the female population, while secondary spontaneous cases are at 6.3 per 100,000 in the male population versus 2 per 100,000 in the female one. Iatrogenic pneumothorax resulting from medical procedures has an incidence of 5 per 10,000 cases. Clinically classified into three main types, the next section will cover those three types and their pathophysiology. The first type is spontaneous pneumothorax occurs due to the rupture of pulmonary blebs or bullae. Next, traumatic pneumothorax results from penetrating or blunt chest injuries. Last one is tension pneumothorax develops when air accumulates under pressure in the pleural space, creating a life-threatening emergency requiring immediate intervention. Spontaneous pneumothorax is classified into two subclassifications. The first is primary. Occurs without apparent cause or underlying lung pathology. Key risk factors include tobacco smoking, a tall, thin body figure, often seen in young adults, and pregnancy. And it typically results from the rupture of small apical blebs, leading to the air escaping into the chest cavity, though the exact etiology remains unclear in many cases. Second, secondary spontaneous pneumothorax develops due to underlying lung pathology. The most common associated conditions are COPD, tuberculosis, and sarcoidosis. These patients require urgent evaluation as their compromised respiratory reserve makes even small air collections clinically significant. Next is the traumatic pneumothorax. It is the accumulation of air in the pleural space resulting from a trauma, hence the name traumatic. It has also specific symptoms like dyspnea, tachycardia, and chest pain. Common causes include rib fractures, flying or skydiving, penetrating trauma from stab or gunshot wounds, and iatrogenic complications. These cases require immediate assessment for potential traumatic pneumothorax development. Traumatic pneumothorax occurs through two primary mechanisms: open penetrating trauma to the chest wall, such as stab wounds, or closed blunt trauma, as seen in rib fractures from impacts. Both require prompt evaluation for potential tension pneumothorax development. Finally, tension pneumothorax is a life-threatening emergency that requires immediate intervention. Develops when injured tissue creates a one-way valve trapping air in the pleural space during inhalation. This leads to rising intrathoracic pressure, lung collapse, and mediastinal shift, a life-threatening emergency. Common triggers include trauma, positive pressure ventilation, tracheostomy, or improperly secured occlusive dressings acting as a one-way valve. Pneumothorax typically presents with sudden stabbing chest pain and acute shortness of breath, the hallmark symptoms. In severe cases, patients may develop bluish skin discoloration and profound fatigue, signaling respiratory compromise and the need for immediate evaluation. Diagnosis begins with physical examination, assessing for reduced breath sounds and hyperresonance. Chest radiography remains the initial imaging choice, while ultrasonography offers rapid bedside evaluation. For complex cases or small pneumothoraxes, CT scanning provides definitive assessment. Management ranges from minimally invasive to surgical interventions. Needle aspiration serves as first-line treatment for primary cases, while tube thoracostomy is indicated for larger or recurrent pneumothoraxes. Advanced options include thoracoscopy for bleb resection or pleurodesis, with pharmacotherapy adjuncts for pain and inflammation control. Electrocautery may be utilized during surgical interventions. Thank you for taking this comprehensive module on pneumothorax. We trust this information will enhance your clinical practice.